Good morning and Assalamu alaikum. Today's session is about the epidemiology and etiology of the urolithiasis. It's very important topic as far as patient management and your exams are concerned. So, doctor,
Assalamu alaikum everyone, good morning. My name is Dr. Mustaq Hussain. Today my topic of presentation is epidemiology and etiology of urolithiasis. Our learning objective of this presentation will be incidence and prevalence of stones and various risk factors in the formation of stone and various theories regarding the pathogenesis and formation of stone. First of all, can any one of you define what is stone?
right? So it's a combination.
Stone is a polycrystalline aggregate composed of varying amount of crystallites and organic matter. Prevalence of stone range from 1 to 15%. Its incidence vary according to the age, gender, race, geographical, climatic, and dietary and genetic factors. The distribution of stone disease vary according to the race. Like in male to female ratio among the whites is 2.3 and among African Americans it's 0.65. Stone, the recurrence rate of stone is almost 10% in 1 year, and also 20% in 2 years, and around 50% in 5 years. So a person with a history of stone has increased risk of recurrence.
Can anyone suggest what's the difference between incidence and the prevalence? We have mentioned the two things over there in the previous slide, right? So you are correct.
Classification of stones. Stones are classified on the various bases. Stone can be classified on the basis of etiology. There can be non-infectious stones, infectious stones, and due to any various genetic problems and any drug stones. Infectious stones include magnesium ammonium phosphate, carbonated apeptide, ammonium urate, while non-infectious include calcium oxalate, phosphate, uric acid, and stones with genetic problems include cysteine, xanthine, and various drug stones involving the cephalosporins, amoxicillins, fluoroquinolones, and dinavir. Stones can be classified on the basis of composition, like calcium oxalate monohydrate, calcium oxalate dihydrate, uric acid stone, ammonium urate, xanthine stone, cysteine stone. Right. On the basis of radio opacity, stones are classified into the three categories. Either they are radio opaque or faintly radio opaque or radiolucent. Radio opaque stones include calcium oxalate dihydrate and calcium oxalate monohydrate and calcium phosphate stone. While cysteine, apeptide, and magnesium ammonium phosphate have poor radio opacity, while uric acid stone, xanthine stone, and ammonium urate and dihydroxyadenine are radiolucent stones. They cannot be visualized on the X-ray. Factors affecting stone include various factors, can be intrinsic factors or extrinsic. Intrinsic factors are non-modifiable. These include first of all is age. The peak incidence of stone formation is in 4 to 6 decades of life, while women show bimodal distribution with second peak in the 6th decade of life. This is because of the fall in the estrogen level after the postmenopause, because estrogen have a protective effect against stone formation by increased secretion of citrate in the urine in female. Male to female ratio of stone formation is 3:1. Males have higher concentration of urinary calcium, oxalate, and uric acid because of the effect of testosterone that causes increased production of the oxalate from the hepatocytes. While females have high urinary concentration of citrate because of the protective effect of the estrogens, that's why they have lower incidence of stone as compared to male in premenopausal age.
So estrogens have multiple mechanisms by which it protects the female from forming the stones. One is the increased excretion or concentration of the citrate. Others are it decreases the bone resorption. It increases the calcium reabsorption from the kidney.
Obesity in patients with obesity and metabolic syndrome having hypertriglyceridemia, hypercholesterolemia, and diabetes are increased risk of the kidney stone disease. Obese patients have increased excretion of the stone-forming substances like oxalate, calcium, uric acid, and phosphorus, and also have low urinary pH. And decreased excretion of stone for preventing substances like citrate in the obese patient. While race and ethnicity also affect the incidence of stone in the patients. Like Caucasians have the highest incidence of stone disease, followed by Hispanians and Africans, and then Asians, and then Africans. Patients with genetic problem and also predisposed to the increased risk of stone disease. Patients with a family history of stone disease are also at high risk of stone formation. A patient with familial renal tubular acidosis, cystinuria, xanthinuria, and patient with primary oxaluria and cystic fibrosis and Leishman syndrome. All these can predispose to the increased risk of stone formation. Then comes to the extrinsic factor. Extrinsic factor are not intrinsic to the patients that can be modified in some cases. First of all is geography. Stone disease is highly prevalent in the hot arid climate due to the increased dehydration and supersaturation of the urine, and also increased specific gravity. However, genetic factors and dietary influences may overweight the effect of geography. Like in African patients have genetic effects having the low incidence of stone disease. Stones are highly prevalent in USA, Scandinavian countries, Mediterranean countries, North India and Pakistan, and also in China. Then is the climate. Those patients exposed to high temperature exhibit have low urinary volume and pH, and also have high uric acid level and high urine specific gravity, leading to high saturation of urine and uric acid, lead to increased production of stone. And occupation where there is a exposure to high ambient temperature like cooks and engineering room personnel have also increased incidence of stone disease. And also in patients with sedentary occupation, because of the westernized diet, they have increased risk of stone disease. And also patients with limited bathroom access like taxi drivers, they also have increased risk of stone disease. And also people with low fluid intake are increased risk of stone formation. But increased water hardness, that is described by the content of calcium carbonate, and decrease the stone formation. But it's not proven. Some evidence are otherwise. High animal protein intake increase the urine oxalate and also decrease the pH of urine and also decrease citrate level, leading to increased stone formation. And high salt intake can lead to hypercalciuria because of the sodium calcium co-transporter, leading to increased calcium in the urine that can precipitate into stone. There are various risk groups that have increased risk of stone formation. Generally, patients with early onset of urolithiasis, like in children and teenagers, they have increased risk of recurrent stone. And patients with familial history of stone disease, and also some genetic problems like cystinuria. And patients with recurrent stone formers are also at increased risk of stone formation and having the short time since the last stone episode. And various metabolic or infectious stones are increased risk of stone formation. And there are also various diseases that increase these stone formation, including hyperparathyroidism, as we have already discussed, metabolic syndrome, nephrocalcinosis, polycystic kidney disease, gastrointestinal diseases that lead to the increased oxalate absorption, and also the bariatric surgeries. They also increase the risk of stone formation, and also the patient with increased level of vitamin D, sarcoidosis, and spinal cord injury and neurogenic bladder, where there is increased stagnation of the urine and infection of the urine, increase the risk of stone formation. Then comes to pathogenesis. Physical event process of stone formation comprises, which is a complex cascade that occurs on the start of the glomerular filtration as it progresses through the nephron. A short video for stone formation.
Stone formed. The first step is nucleation. Ions such as calcium and oxalate that have been filtered into the urine by the kidney spontaneously join together to form a solid crystal nidus. This is called nucleation. There are two kinds of nucleation. In homogeneous nucleation, crystals form around a nucleus with the same composition. Crystals of a different composition can also form around the nucleus. Organic material, such as cell debris, may be deposited between the crystals as a matrix. This is heterogeneous nucleation. The tiny crystal formations travel down the nephron and are usually deposited at the renal papilla, where they undergo the next major phase, growth. Crystals that have already formed then begin to stick together, forming large aggregates. As we can see, crystals can aggregate very quickly. Mu stones are retained in the kidney, where they can continue to grow for an unspecified length of time until, for reasons that are not well understood, they are displaced and travel through the kidney into the ureter. If a stone continues to grow until it reaches a critical size, which can be as small as 4 to 5 millimeters in diameter, it may be too large to pass easily through the ureter. The edges of the stone may become wedged inside the ureter at the ureteropelvic junction, where the ureter crosses over the iliac artery, or at the ureterovesical junction. The result, pain and obstruction, until the stone slowly passes into the bladder and eventually passes out of the body in the urine stream. Stone form.
As we have seen, the steps of stone formation include, first of all, is the supersaturation of the urine, followed by enucleation, and then growth and aggregation of further crystals, and also retention in the various tubules and in urinary system. Before discussing the pathogenesis of stones, first discuss the few basic concepts and few terminology. First of all, what is the concentration product? Concentration product of any solution is a mathematical product of concentration of pure chemical components like ions or molecule of a salt in a solution. Like in a solution of sodium chloride, it's the concentration product of sodium ions and chloride and in that solution. It's called concentration product. Thermodynamic solubility product. When we dissolve a solute in a solution, a point reached at which the dissolved form and the crystallized form are both in equilibrium. This state is called state of saturation. The concentration product of ions and molecules at this point is called the solubility product. At the point of saturation, one condition must remain same, that's the temperature and pH. Then is the formation product. If we keep on adding the solute in the same solution, a point reached at which even in the presence of inhibitors or crystals, the solute will crystallize. At this point, the concentration product of the ions and molecule in solution is called formation product. So let's discuss the few states of saturation. What is an undersaturated solution? A solution in which more solutes can be absorbed without and dissolved without crystallizing is called undersaturated. And then we have, as discussed, the state of saturation is reached. And then is a state called metastable state. It's beyond the saturation level, but the solutes will not crystallize because of the presence of various inhibitors that inhibit the formation of crystallization. In the metastable zone, either homogeneous nucleation does not occur, but in the presence of any nidus or any other cell debris, the crystallization can occur over this nidus. And in this case, heterogeneous nucleation can occur. After this, then is a state called supersaturation or unstable state, at which even in the presence of inhibitors, the solutes will crystallize and stone will form. As it is, metastability is a state between the concentration, where the concentration product of salt lies between solubility and formation product. To estimate the state of saturation of a given crystal system, various computer-based programs have been formed. These include Equal2 and JESS program that can estimate the saturation of a urine and also predict the risk of stone formation. As we have already discussed, nucleation. What is nucleation? Nucleation is the earliest crystal that will not dissolve in a solution, and it can be of two types: homogeneous nucleation or heterogeneous nucleation. In homogeneous nucleation, nuclei form is a pure solution. It has same composition with no other precipitating factors. While in heterogeneous nucleation, the crystal adsorbs on an existing surface. That could be an epithelial cell, cell debris, or any other form of crystal. Formation of stone is a very poorly understood. Various theories have been described over the era to describe the formation of stone. And these include the nucleation theory, crystal inhibitors theory, fixed particle theory, that's also known as Randall plug theory, nanoparticle theory, ductile plug theory, also known as mass precipitation or intranuptial calcinopathy, and also unified theory that combine the pathogenesis of Randall plug and ductile plug theory, and also the core hypothesis.
I would like to add the important concept regarding the inhibitors. The concentration or the urine is mostly supersaturated, but there are certain things in the urine like time hospital proteins, glycoproteins. So there are various inhibitors that prevent the stone formation.
First is the nucleation theory. As I has already discussed, the majority of solutes in human urine are in supersaturation state, but usually the crystals don't form because of the presence of various inhibitors. According to nucleation theory, urinary stone originate from a crystal or other nidai immersed in a supersaturated solution. Initially, a nuclei is formed, but if it is small size, below a specific threshold size, it will dissolve or it will pass away. But when it grows to a specific size, it persists and it causes the crystals in the solute to deposit over it and leading to further aggregation of crystal and enlargement of size and lead to formation of stone. But the arguments against it that the time transit of urine through the nephron is almost 5 to 7 minutes. That crystals cannot grow to such a size that can occlude the tubular lumen and provide time for the aggregation and growth. Then comes the crystal inhibitors theory. According to this theory, calculi can form in the absence of low concentration of natural stone inhibitors like magnesium citrate, pyrophosphate, and other variety of trans materials. But few evidence are against it that many people lacking such inhibitors do not never have a stone in the whole life, while other with abundance of inhibitor can form these stones. Then comes the fixed particle or Randall plaque theory. It was described first by the Randall when he observed the subepithelial deposit at the renal papilla in the autopsy findings of various patients with stone disease. And he described that there is an anchoring site to which the crystals bind and provide the time for the crystals to expose to supersaturated urine and facilitate its growth and aggregation. This theory is usually indicated in the formation of idiopathic calcium oxalate stone formers. In this, initially an epithet crystals deposit at the basement membrane of the distal thin limb of loop of Henle, and it gradually grows and invades into the interstitium and predispose the inflammation and also causes the deposition of more calcium and oxalate crystal and reach the subepithelial level. Epithelial erosion due to any oxidative stress exposes these crystals to the urinary system and causes the aggregation of stones over it, and that can be in the alternative layer of crystals and organic matrix and causes the growth of stones. Then comes the nanoparticle theory. It's an unproven hypothesis for the origin of calcium phosphate crystal. According to it, stones formed by calcification of various nanoparticles, like the process that is implicated in various pathological process of calcification. Stoller defined that the inciting event might be any vascular injury, like vascular injury to the vasa recta leads to the initiation of a repair process like an atherosclerotic action that can cause the deposition of various solutes and erode into the papillary interstitium and further extend to the collecting bone. Then came the ductal plug theory. According to this theory, in a supersaturated urine, epithet crystal deposit and plug in the various medullary collecting ducts and cause stagnation and provide time for the aggregations of further solutes that can injure the surrounding collecting duct cells and cause the enlargement of collecting duct and surrounding inflammation and fibrosis and propagating the further stone formation. Ductal plug theory is implicated in glucide stone formations. Presence of ductal plug raise the suspicion of secondary cause of stone formation. Like we discussed, the idiopathic calcium oxalate stone forms are mainly explained by the Randall plug theory. And it is observed in various metabolic conditions like enteric hyperoxaluria, renal tubular acidosis, hyperparathyroidism, and cystinuria. Khan et al. Proposed a unified theory of the formation of plaques and plugs. According to him, both processes are go side by side in stone formation. Like in the proximal, at the papilla, in the loop of Henle, the crystals of epithet are deposited and that invades the interstitium. When it comes contact with the collagen fibers, they activate the inflammatory process and lead to the deposition of further salts and purification of dental plaques that erodes the epithelium and comes in contact with the urine of the tubules, leading to further deposition of calcium oxalate crystals and also the organic matrix in a laminated form. And also at the same time, he said that during the supersaturation and slow transit of urine from the ducts lead to the formation of crystals and aggregation that can plug in the collecting duct, creating local inflammation and involvement of the stony tissue and further deposition of crystals and formation of stones. Carrs hypothesized that the calculi form in the obstetric lymphatics that rupture into the adjacent fornix of relic, but the arguing against the Carr's theory are that lofty visible stone with early stone elements can also be found in the area remote from the fornix, so it's not always from the lymphatic. So the pathogenesis of stone is not clearly understood. Different people have described the different hypotheses.
The etiology or pathogenesis of stone is not clearly understood, still present. There are various theories regarding its formation, but none of them have been proven so far. The reason, one of the evidence of it is around one third of the patient will be having normal 24-hour urine metabolic state. It will be normal citrate level, normal sodium, calcium, and all of the other ions will be normal, but patient still be having stone formation. What your comments, sir?
Yes, there are many theories, and again, these theories they have their kind of adage every now and then. So, for instance, one name was mentioned here earlier in the slides. Just not. So, this is Dr. Saeed Khan, and he's a basic scientist, and he is in Gainesville, Florida, USA. So he visited us quite often, maybe 3 or 4 times, and he has done quite a lot in terms of pathogenesis or etiology of uh, stone formation. But again, that doesn't hold for each and every person living in each and every corner of the whole globe. So maybe a stone developed in Scandinavia has got a different kind of as compared to maybe sub-Saharan Africa or Pakistan, India. But again, there are certain elements, as you have rightly pointed out earlier, that have their contribution in just combating the crystal aggregation, and these are very important. Rather than stopping the crystals to aggregate, if they aggregate on their own, if your diet has got something which may be an increase in the amount of fluid, or maybe some element of anything which is against crystal aggregation. For instance, tamarind is one thing which is very commonly used in south of India, in Kerala, for instance, Karnataka, and they have got very low incidence in the whole subcontinent of this disease, that is stone disease. So they have proposed, and the doctors over there, the urologists, they have proposed that by adding tamarind in the diet to maybe a very high concentration, because they use it at a very high concentration. We might use it in our own cuisines, but not to that extent. So it can stop crystal aggregation and the stones cannot be formed. But again, I don't know whether it's the whole sequence of environment plus diet plus genetics, or maybe it's something else. So there are many factors. Earlier, there was a theory that it is very common in certain blood group of patients. So that is something which is there, but again, it's not a one-to-one correspondence that every blood group A patient has got stone disease looming around. So it is this subject is open to anything that that can be added to it. You can add your theory to it with your name in it. But one thing is common, that if you increase the amount of fluid, that can save you from having stones. Interestingly, there was one person who came from somewhere in Europe, and he stayed for a very long time in Tharparkar, and he had a very good kind of a very interesting kind of observation. He said that in that area, which where people don't have potable water, they drink habitually very little, but they don't have that much of stone disease as is expected. Why? Because their diet is low in proteins, animal proteins. So what they have called they have got vegetables and pulses rather than having other things. So and again, he also observed that in the Muslim community living in Sindh, they have got a very low incidence of stone disease and colic in the month of Ramadan at that time, maybe 30, 40 years back. So why? I don't know. But again, that was his observation way back, maybe 25, 30 years.
Right, sir. There are various promoters and inhibitors some facilitate the stone formation at various steps, like there are certain inhibitors that prevent the stone formation at various steps, like two prevents the nucleation, the other prevents the crystals from aggregation. So it's as rightly said, it's a wide open topic of stone formation and pathogenesis etiology. Yes, Doctor.
I just want to make a comment here. Though, as you already mentioned, that it's we don't know exact pathogenesis and the causes for sure at the moment. But there are certain factors which we know for sure, like Dr. Sir was mentioning about increased amount of fluid, and then red meat and things like that. So for now, it's not like that we can't do anything for the recurrent stone former or thing like this. So being a physician and the clinician, we can do a lot of things which is being missed in our regular practice. The important thing is when a patient gets stone free or he is on like regular follow up with a small, tiny, non-obstructing stone, and we know that he's a recurrent stone former, we should get a metabolic workup done. Uh, yes, you are right that many of the cases we don't find any abnormality there, but there are cases where we find such things which can be corrected and patient can be managed accordingly. And everyone in the who is doing clinic should know that how to send the sample and how to interpret it. It is very important. And for there are at least two types of management. One is the specific preventive measures which you offered according to the reports, but there are general preventive measures. If someone asks you, Doctor Saab, मैं क्या नहीं करूं, so at least being in a urology, we should know okay, what to tell them: increase amount of fluid or red meat or edit salts or things like this. So for everyone, this should be in mind.
At the moment, there is one project which is going on, and it is precisely on what Shua has said, and it is by the nutrition department of SIUT. And what they are looking for is just an association of stone incidence or stone prevalence, rather, with vis-a-vis metabolic syndrome. So if any person has got diabetes or maybe hypertension, hyperlipidemia, obese, these people, they have got a higher propensity of having stones. So it's a large cohort. Let's see what they will come up with their project, and it will be a very simple kind of a message, but it will be something which gives us confidence in telling somebody to use something and not to use some other things. A blanket statement giving to a patient, for instance, not to eat too much of protein is also which is not on, because protein is something which has to be there in the diet. We all must be aware of the fact that there are two classes of protein, rather class 1 and class 2 proteins. So whenever you are telling somebody to stop protein, you are not telling them to stop at all, because a 1 gram per kilogram body weight protein is something which is necessary even for a person who is on dialysis. So you see, whenever a statement is given out of the mouth of a urologist, this has to have a backing of science, and it has to be a scientific notation rather than just a statement.
One has to look into these factors, that how much meat a person is taking in. We're not living in a society where people are eating too much of meat. We are not living in a society where people thrive on McDonald's. So there are very, very few people who eat lots of meat. So that has to be taken into consideration as well, that how much meat is being taken in by the patient to ask him to stop it. So if it is a very small amount of meat, he can continue with it. And one more interesting fact that I read in one of these studies is about the atherosclerotic plaques that you mentioned. That some researchers had found that people who would sleep on one side of their body, like if they sleep सीधी करवट पे, उल्टी करवट पे सो रहे हैं, so the stone would form more on that side because that would increase the blood pressure on that particular kidney, and that would result in vascular injury and atherosclerotic plaque and stone formation. So that is something interesting that I went through a few years back.
Dr. Naveed, can we have comment from your side? No.
Very nice presentation, Dr. Mushtaq. Congratulations. बड़ी अच्छी discussion रही. Thank you so much.
Thank you.